So today we talked about manic episodes and major depressive episodes. The slides that are posted have a lot about that. One thing in particular to focus on is the effects of lithium. What it does is it doesn't interfere with the G proteins themselves or the receptors, but instead interferes with some of the internal signaling for the GS and GO receptors. Remember, some of these GO receptors are part of what or maybe too active in major depressive disorder, so that may explain in part why lithium has some effects for managing depressive symptoms. Also, by altering GS, somewhat similar to the anti-epileptics, it may just make various parts of the brain less excitable. And by making various parts of the brain less excitable, it's going to decrease the chance that the brain is going to sort of tip over into a manic state. However, lithium has a pretty narrow therapeutic index, and there's two reasons for that. One is that every neuron has neurotransmitter receptors. There are many other neurotransmitters that use G proteins, and lithium is going to affect all of those. Plus, even these receptors have effects in terms of cognition and attention, and so lithium can, depending on the individual, sometimes cause cognitive problems at a lower dose or at the same dose where they're getting therapeutic effects. In addition to that, there are G protein coupled receptors all over the body involved in digestion and liver function, and that can cause side effects in the body, including dangerous side effects like liver failure. Despite that, lithium can be very effective for managing bipolar disorder. And there are many patients who do find the right dose for lithium that works for them. The second thing that we talked about is the Dutra study. So they were looking at this anticipation task where they had people expecting either a reward or expecting a compliment or maybe expecting nothing at all. And what they found is that, looking at activity in the nucleus accumbens, what they found is that there was a bigger, in bipolar patients who were not in a manic state, the nucleus accumbens showed higher levels of activity during this anticipation. So what that means is that bipolar patients have a more excitable nucleus accumbens, and that this increases the risk that they might tip into a state where their nucleus accumbens is too active, and a too active nucleus accumbens actually does really effectively sort of mimic what one might expect to see with bipolar disorder in terms of feeling very good about things, feeling like you're very lucky and that you can take risks, feeling very capable. These are all things that would occur if somebody had an overactive nucleus accumbens. So in this study, they thought that it was a disease marker, although they didn't do the full set of controls, including relatives, to guarantee that it wasn't a risk factor. And then the next part that we talked about, which we're going to come back to next time, is it turns out that there are brain areas where you see differences, where you see situations where healthy siblings are different from their relatives with the disease, but also different from controls. And that's a little bit odd to think about, but we'll talk about what that means on Monday.